Does that mean we're going to either merge with the MDs and DOs to be in hospitals? Because I personally have had, experience in the ER and stuff like that. A lot of the kids don't get that experience,
It'll be important to integrate the awareness of our profession, the chiropractic profession, into medical training. Okay. And that will be a two-way street, of course. When chiropractic interns who go into a hospital setting as a trainee, it's usually a very limited period of time, but it reinforces their decision process. They have a better understanding of their skill set. They're recognizing that their knowledge base is quite similar, right. Especially outside of surgical and pharmacologic treatments. Mm-hmm. So, on the other hand, what that brings into the field of medicine and osteopathy is an understanding, a contribution of integrative healthcare, mm-hmm. healthcare from the integrative standpoint. Historically, medicine, and to a great extent osteopathy, has fragmented the patient. So you have a nephrologist who takes care of the kidney, and a pulmonologist who takes care of the lungs, and cardiologist for the heart. That kind of approach is very good for acute care. It's demonstrated a long history of success for acute care. But that's insufficient for the management of patients with chronic healthcare problems. It's necessary at some point when the patient becomes acute. Mm-hmm. But the day-to-day management of patients in chronic pain and other chronic disorders and disease requires a more holistic view in order to provide success in their care. So education in a hospital setting would be valuable for both trainees in the chiropractic as well as in the medical disciplines, osteopathy disciplines. So that I think is going to be important as a resource, as an educational resource. Historically, the chiropractic training has never included hospital, but increasingly access to that training environment will be necessary. Is it a merger with medicine? In some respects, educationally, yes. Politically, not at all. I don't think that's ever going to happen. Separate discipline is going to be, I think, the future in this profession. Okay. So we don't become a subspecialty of medicine. No, I don't think so. Mm-hmm. I don't foresee that. But we need educational interaction with all healthcare providers, especially in medicine, and that's the benefit of the patient, is to serve the patient.
Yeah. I see a lot of what you're talking about, the specialization, and patients getting handed off and handed off and handed off until finally somebody gets the patient, and it's a little bit too far gone by then.
Well, you're right. A delay in diagnosis usually means a delay in treatment, in the appropriate treatment. And that costs patients quality of life, that costs in terms of financial impact, society. So, but I think most importantly, it frustrates patients, and it makes them adverse to seeking healthcare opinion in general.
They do.
So, on the other hand, there are patients who are doctor shoppers, and they don't serve the system. We need a way to track those kinds of patients, especially if medications, pain medications, are one of their sources of motivation. Mm-hmm. But the delay in a diagnosis because of multiple clinical visits across multiple disciplines, that's a problem.
That's costly.
And no clinician, regardless of the discipline, will be able to solve that. That's a social problem, I believe, the way the system is set up. We have a long way to go to address that.
Okay.
That means changes in the system itself. Maybe healthcare reform could address that. I'm not sure it will.
Okay.
If system-wide changes need to be performed. And there are some rational, logical solutions. Start with the most conservative care. A trial of care in the most conservative care, that fails, moves the patient into the next level of intervention. Failing that, they move into the next level of intervention. Chiropractic management would be a reasonable place to start with neuromusculoskeletal disorders.
Right.
Triaging the patient after that into orthopedics or neurology or neurosurgery or internal medicine if that's a direction that's necessary. It makes a lot of sense. So, I'm hopeful that's an exploration, that's a direction that the reform, if it occurs, would explore.
Right.
Because without that kind of efficiency in the system, and I believe it would be more efficient, we're using acute care medicine to manage chronic care problems. That's destined to fail. There's no motivation for patients, number one, to manage their health. There's no motivation for lifestyle changes that reduce disease risk factors. That's a problem.
Mm-hmm.
A big problem.
I see that a lot in the ER.
Well, the ER is the focus of acute care.
Yeah.
And how many patients are in the emergency room who 20 years ago, 30 years ago, as they were walking down the aisle of the supermarket, put in a six-pack of beer instead of bananas.
Mm-hmm.
So they made decisions
Yeah.
that are coming back to visit them.
Yeah.
And many of the chronic disease processes are, in fact, diseases of choice in a way that choice was responsible. Choices by the patient
Right.
turn out to be the basis for a lot of the pathophysiology that drives chronic disease.
Mm-hmm.
So their responsibility has to be recognized. Mm-hmm. And patients have to see that role and more importantly, live in that role. But providers can't preach to patients. Patients need realization.
Mm-hmm.
They have to undergo a transformation in their consciousness, and they go, oh, that's my responsibility. Oh, and I could eat better, and I could exercise more, and I could think more positive thoughts. They need to catch that notion and that idea, and we need to help them with that.
Mm-hmm.
That's going to be the challenge of the future of healthcare, regardless of the discipline. But you can't do that in the emergency room. You're trying to keep their pulse
Right.
and their EEG from going
Right.
flatline.
Right.
So after that or before that, that's where these are applied. But I really think that pediatrics should be the leverage point. So you don't treat osteoporosis in an 80-year-old. You should be treating it in a 10-year-old who's coming out of the grocery store with their arms around a barrel of 7-Eleven Slurpee or something.
Right.
That's where the leverage has to be applied because they're building now the lifestyle for osteoporosis and many other chronic diseases. I think we have to put the leverage into the age group of pediatrics, and that means public health as well. Mm-hmm. So we've got a lot of work to do there to really leverage healthcare in lifestyle changes. We have to go down into the pediatric age room while they're formulating their diet strategies and their preferences. That's where we have to interact with them more effectively to bring impact on diseases that are coming 30 years from now, 40 years from now, and beyond. Because then all you have left is emergency care. Yeah. It's very expensive care. And it's short-lived.